welcome everybody. Thank you for your interest in our process. We have a little spark on all this PCN process because we did manage to secure funding for a nurse practitioner in our clinic. As Angie mentioned, we live and work on Gabriola Island, which is the name of unceded territory. It's a relatively small island. We have from 5,000 to 6,000 residents. There used to be 3 doctors when we were applying for this position. So we were quite desperate for help because we were all overworked and we were struggling with reality of work in primary care. Our community is quite monolithic, meaning it's 99% white people. So it's quite easy to organize services for our community. This way, there is not too much variety. And so we started talking about, we actually didn't start talking about having a nurse. We kind of mentioned having a nurse, how useful it would be before, and it was very loose talk because we never thought that we could afford to have a nurse. Previously, we would have to hire a nurse, and every time when we look into hiring a nurse, it was a cost neutral effect for our upkeep, but together with more time and more staff to manage her list, we felt that we will just not manage financially at all to have a nurse. We couldn't afford it. And I'll probably switch to presentation that Angela did start. Share the screen with you guys. Here we go. There we go. So I want to acknowledge that in any successful enterprise, it takes a team. You know, nobody alone is successful. There's always a very supportive team of really engaged, interested people. And so it was in this process, and Angela here did probably 80% of the work when it comes to organizing our nurse to come over. So I want to acknowledge that. Then a lot of work was done by our practice manager, Carol Farr, who together with Angela, they were really polishing and ironing out details. And I don't think it's an enterprise anyone can take on alone because it's just not enough time to deal with this issue. So in our case, what happened is we were lucky because Jennifer Lewis, who is a USA resident, came to visit the island and fell in love with it, bought a property several years ago. And she's been visiting our clinic, dropping her CV saying, I want to work here, guys. And I don't know how to do it, but I want to work. And I think it was 2-3 years. It was probably 2017 when she came in first time and dropped some paperwork. And we really couldn't help her. We couldn't see how this would all work. But then finally in 2019, she came in and we started talking about this. And I don't remember who made us aware or who knew that there could be something called Illy Draw from Primary Care Network that could make it possible to establish a budget for her and establish a role in the clinic. And our physician lead, Tracy Thorne, at the time, met with Jennifer and was very excited talking to her because Jennifer was obviously very qualified to work in primary care and emergency settings too. This is exactly what's happening on Gabriola. We didn't really know how to move on. So in February 2020, we had a meeting, our CSC meeting, and Sheila Ledbetter, who's executive director for Nanaimo Mental Health Substance Use, she knew about the process more than we did, and she helped us do the first early steps. And guys, please do stop me if you have any questions. I think it might be easier to address them here. If anyone would like to have those slides, I'm very happy to provide you a copy. This is just our way. I don't think it's an instruction how to get a nurse. This is just what happens with us. So the first part was relatively easy. First part was basically restricted to trying to get her position accepted and get a contract ready for her. So we had several meetings starting in May 2020, and it all went till October. We met with Ministry of Health and VHA in the meetings, and I must say, you know, they were really keen to help us out, and there was a lot of enthusiasm in those meetings, and we are all working hard to make it work. But in the same time, the process was somehow confusing because it was a new thing for everybody. You know, the rural PCNs do not even exist yet, and yet we are applying for funding from one. So it wasn't without hiccups and difficulties. And sometimes we had problem with paperwork when Ministry of Health would approve a specific part of a paperwork, and then we could not find the approval, and we were playing a telephone tag. And then it was coming back to Carol Farr, our manager, and Angela, basically just coordinating efforts, finding the right documents, finding out who is the person to deliver the document to. So this was not without confusion. But finally, we reached the step when we were negotiating a contract for Jennifer. And the contract for a nurse practitioner is a standard contract that the Island Health has for nurse practitioners. And they basically presented us with the contract. Nobody was sure how much wiggle room there will be to discuss the details. And in fact, there was not much room to discuss the details. We were presented with the contract, and some of the things initially presented change a few months down the line. And so in May and October, when we were talking about this, the November version of the contract was actually different. I think the biggest problem for us from an organizational point of view was that it turned out that there will be no coverage for our nurse practitioner when she goes on for holiday, and she has 6 weeks of holidays. And basically somehow this became the responsibility of local providers to provide coverage for her patients, for her paperwork when she's away. Something we were not made aware in the beginning, but our community was so desperate for providers, we had to have some help. We decided to go along with it regardless. There is no additional finances, to cover for her holidays. We basically were told that this is what will happen. So we signed the contract in November 2020. And then basically in December, we started to get administrative things done. And by administrative things done, I mean, Jennifer is not Canadian, so she does require the work permit. She had to have a job offer for that. The contract had to be approved officially by the Island Health and the Ministry of Health. Then the job actually had to be posted. And this is the interesting part, because it would be illegal to have a candidate and set up a job position for it. It needs to be open for other nurse practitioners. So we did provide the job description requiring a nurse to live on the island and work on the island. And we posted it, I think, for a week, Angela. I think it was about a week. But there were no other interested parties. Jennifer was the only one, and she got the contract. And to be entirely honest with all of you, I think this process would be impossible if you don't actually have a candidate already before starting of the process. I know there's many open positions for nurse practitioners, and there is a big push to use these services more, as we should, but there is not many candidates out there. I know Salt Spring Island has been trying for a very long time now to recruit a nurse practitioner, and they've not been successful. Even so, they have a good job position over there. And I think that's similar to many communities. So we just got very lucky with a nurse practitioner just choosing to live here and then getting in touch. And if it wasn't for her, we would never start this process. And so in the beginning of 2021, we had to apply for MSP number for her. The immigration documents had to be all processed. And then in this time, both Angela and Carol, our practice manager, they spent a lot of time trying to sort out EPE status, data center, things I didn't even know exist as a doctor, but it's all to do with zero billing, with her reporting and counters and getting basically monitored and paid appropriately. She started working basically beginning of 2021, and straight away in February it turned out that none of her billing was working, that there was a problem with all the issues when it comes to her reporting, the patient encounters, billing. This process was just not working, and it was a bit of a nightmare because nobody really knew to do. And as much VHA as they were trying to be helpful, they didn't know who could help us with this. So this process was driven by Angela and Carol calling the billing place, calling the VHA, calling MSP numbers, having multiple discussions. I think, how many hours, Angela, do you think you guys spend on this? I think easily over a dozen, just for this one issue to really try to figure it out. And basically in March, a month after Jennifer started, the billings were all rejected and we were all struggling. And between March and August, we managed to solve this problem by trial and error and trying to find the right people. Whereas in August 2021, GPSC released a document entitled Encounter Reporting for primary care clinics. And this is a really useful document for anybody who is interested in employing a nurse. And it really helps with this admin part of basically recruitment and establishing a nurse. I would also say that by now, both Angela and Carol are probably experts in this, and they could help you guys with some advice. So if you have any questions, just contact Gabriola Medical Clinic, send an email to practice manager, and I'm sure they will try to be as helpful as they can. They went through the process, they discovered all the little nuances, and they did it by themselves without the document. And that was really helpful. So if you guys will have any issues or questions, please contact us. We'll obviously try to help. The positive part of the problem, it was the energy. And I think it's a little bit like those PCNs coming to rural places. Nobody knows what they will be like. Nobody will know if they'll be funded appropriately, but it's a new, exciting model. And both ministry and VHA were very enthusiastic, and they wanted us to have more services. They wanted this to work. VHA took on the administrative way, they're looking after Jennifer, and they really wanted everything to work well. Having said that, none of the stakeholders, the VHA, the ministry, knew exactly how this will work, hence all the problems. The contract was a collaborative process. I mean, we could always ask questions parts of the contract. Not that we were given what we wanted, or the contract was changed in a major way, but basically everyone was very open-minded about the contract, and there was no confusion. We were always very honest about what's happening. So was VHA, so was the ministry. We had a great support from Erin, and Angela, correct me, Erin is NNPABC, which I think is a nurse practitioner support group in Vancouver Island. Is that what it is?
Yeah, I should have written it out all the way, but National Nurse Practitioner Association of BC. They were really helpful, though.
Mm-hmm. And they were very helpful with both helping us understand Jennifer's role and helping Jennifer herself, helping her understanding her position and what her responsibilities and duties are. And in the end of this process, we have a nurse practitioner, and she's a wonderful, wonderful addition to our team. She does the same job as primary care providers, and she is wonderful to have around. We're also lucky that she comes with slightly different cultural background, giving us yet another perspective on what we do daily. And we, it really enhances our team to have somebody with fresh look on things. And it's very interesting to see how she does medicine, because she is a mature provider. She's worked in healthcare for many years. And it's very interesting how many discussions this stimulated amongst ourselves, what's evidence-based, what's not evidence-based, what works. And we all learn from each other. There were, as usual with new process, there are challenges. And, the first one was nobody understood the details. We all knew the general idea that the nurse practitioner will be funded by the funds secured from primary care network. The funds were going to be administered by VHA, and the job description part and the contract was being negotiated as, so we had influence on the job description, and we are very happy about this because we could tailor it to Gabriola's need. But the process was bumpy and there was lots of delays. The administration, it was a challenge, and it's a bit of a grinding work. And I think if in the times when we had basically COVID-19 and we were actually quite overstretched in our clinic, out of 3 doctors, 1 was leaving and we didn't have a replacement yet. So there was this really existential threat to the whole clinic too. So they were not the happy times on Gabriola Clinic. We were really struggling a little bit for time to just understand what's happening. So it's good to have someone like a practice manager who would have capacity. So I would say if anyone undertakes this, they should probably plan to have 20 hours for a practice manager to basically book for it and book it out so that she can troubleshoot problems. And that's right. And the only real challenge for us, something that surprised us in a negative way, was this lack of coverage for Jennifer's holiday time, because 6 weeks is a lot to put on primary care providers to cover for a colleague. And there is no, provision for this. There is no compensation for this. So we had to agree we'll just volunteer our time again and just do it. And we did it for the need of survival. We did it for our community. We did it because overall, the community and the clinic is better off. So overall, the process is very positive. But we would love to be in a situation when there is more nurse practitioners where VIHA could provide cross coverage, because that was initially what they told us, that when our nurse goes for holiday, we will be able to get a nurse from Nanaimo. Helen.
Yeah, thanks. You said I could ask questions. I didn't realize that you wouldn't be able to be compensated for seeing the NP's patients.
No, we are not. And the reason for that is because as it is right now, we are on a contract to provide primary care to our own patients and any patients on Gabriola, and we cannot be compensated in any additional way for seeing patients on Gabriola.
Just on this one point, I see a couple of messages in the chat about locum coverage for NPs. The first one was from Karen, and she says that their NP has organized a locum. Karen, do you want to maybe give us an idea of how that worked?
Yeah, happily. I'm not actually sure of the details of it, but we also have an early draw NP and had a lot of the same frustrations, and the process also took a year. But the NP, and we love having the NP in our office and working with her. When she went away this summer, she had a locum, another NP that was also great. But my understanding is that she also can hire one of us to cover her days, and she pays a salaried or sessional rate for that. I hope I understand it correctly.
Karen, would you mind if we reached you later on to figure out how did you guys do it? Because that's a part we did not figure out, and VIHA kind of left us with this saying, you guys just have to swallow it. You need to deal with it. And they asked us if we still want to continue with the process, and we said yes, we do. But there was no other constructive solution to this problem. So I'm very curious. Also, I think in our place, because we are slightly isolated, it would be harder to find a nurse willing to come and commute to the island to work. But it's super interesting, Karen, to hear that this works for you. So that's wonderful.
And apparently as well, she is able to hire a physician for that coverage. And I'm not 100% certain how that works, but I'm happy to connect you so that we can figure it out.
That'd be wonderful. The only drawback of this problem now would be if she would be hiring us, meaning she would be paying us, meaning she would earn less, and that's not what she signed up for. So that creates this personal conflict, because I don't think we would want to upset her saying, well, from now on, after you establish, now you need to start paying us for covering you. It's this kind of a conflict kind of drops to people who actually do the work, and I don't think that should be right. That should be conflict between us and either Ministry of Health or VIHA, and not between the practitioners themselves, because we don't want to take advantage of her now and change things in a way. But I'm still very curious to see, how did you guys make it work, and maybe a replacement. Maybe we could go back to VIHA and talk to them. I'm very curious. Thank you.
Yeah, I think there's several rubs like that, where our nurse practitioner has a 3-year contract that's now maybe more than 50% done, and our overhead has gone up significantly. And so then how do you have those conversations when you renew the contract at the end of the 3-year term? We're thinking of taking on 2 more nurse practitioners. That then becomes a significant part of our overhead. And how do we make sure that we all contribute equally? There are all these, they're just tensions, and I'm pretty sure they're resolvable. But I agree with you that they shouldn't be at a personal level, that hopefully we can get some resolution to these at a much higher level.
That's true, Karen. I think this is so very true. We had to get an additional MOA part-time to make sure that we have enough MOAs to help us with the work. And also nurses see less patients that doctors do. They have half-an-hour appointments. So when it comes to money, she's paid to the actual number of patients. We all know that this is actually a higher proportion than what doctors are getting paid, and it stimulates all sorts of discussions. And I think I was hoping that maybe somewhere in the process, the PCN process will actually look in primary care and say, listen, guys, we will have to pay your overhead to equalize the playing field, because there's so many inequalities between even primary care and specialist services. You know, historically, our specialist colleagues were managed to secure much better deals, and this is historic, I think. It's not economic, and I don't think that reflects the value of what specialists provide to communities compared to primary care. So there's this big discussion, broad discussion, that needs to be taken, I think, as part of this PCN implementation, and I hope somebody will bring it up and we can talk about this. It's very hard when it becomes personal like this. And Karin, you know, with 2 more new nurse practitioners, you know, how much do you charge them for overhead? You know, how does the system work? And it's a problem because then it's you against your colleague whom you want to stay in the community, who's already struggling to find a house because nobody can buy a house. Those discussions are very difficult, and they just drop on our lap at the moment. So I hope there will be some help in the future with this. Yeah, let me just go back to presentation. So the other part of the nurse joining us was communication with our. I'm just going to have a look in the chat. Angela, if you could have a look to see if there's any questions there, because I think it shows.
Yeah, I thought we might also touch on those at the end. We can go through the questions in the chat.
So
I see, sorry to interrupt. I see Don has his hand up.
Oh, I'm sorry, Don. Don, go ahead.
Thank you, Maciej, and also Karen asked one of my questions, but you started to talk a little about this, and I wasn't sure whether you were going to talk about the physician negotiation for contracts, that part of it, because clearly how a nurse practitioner relates to the physicians can be reflected in those negotiations, but I wasn't sure if that was part of your talk.
It wasn't, but let me just, I was asked just to talk about the process with a nurse, but for people who don't know, we managed to secure a contract for physicians on Gabriola Island, and that was again through negotiations. And it was very interesting. It was a similar negotiation, meaning it wasn't really a negotiation. We were given a flat contract that exists in other communities, and there was no wiggle room whatsoever. So the contract is not modifiable, meaning from a rural perspective, in different geographic communities, it doesn't work. It's better than the previous system, but it doesn't work ideally. And for example, we lost any coverage for our emergency services, which is really not great. So I think those 2 contracts, the way VHA can negotiate at the moment is not ideal. I hope that the new contracts for both nurse practitioners and doctors in rural communities will be modifiable, meaning if a specific clinic has a specific need, they should reflect it in the contract. They should be able to add it, because people do obstetric job, they do palliative care, people do home visits, people do provide care for special populations, you know, addiction work. It's a completely different way of working and billing and thinking about work than it would be in a normal urban center. So I think this is an interesting discussion, Don, and I think this is a very broad topic, and I hope it will be developed as PCNs are coming in. Another part of anybody joining to a community is how do we communicate with our own patients, with our community about this. And we had an article, and this is a copy of it. I think this is a copy of our entrance to our Facebook website, but we also had an article in a local newspaper when the journalist discussed her joining, talking a little bit about her, talking about her responsibilities, what she will do, how she will work. And then we used our social media outlets to just inform people, and we had a wonderful response. There was lots of people, you know, really happy that there was a new practitioner welcoming her, and it was a very, very good experience, I think, also for Jennifer. And then, yeah, then the integration to the clinic, you know, it was a very interesting process. We had asked today was the last day when we had the Wolf EMR system. We are moving to MedAccess tomorrow, but our nurse never seen Wolf system, so she had to learn the new EMR. There were slight differences in practices. There were slight differences in communication with patients. You know, we had to create space. We have one major office that used to be just Tracy and me, you know, half seeing the patients, half talking and sorting word problems. And now suddenly we have 5 practitioners there, all talking and having ideas. So it's a little bit like having, you know, a family with many siblings. There's lots of discussions going on, and it's all fascinating, and we could just go on and on and on. So we all had to learn to work the new time, and this takes time. We were basically thinking about logistics. We were thinking if we have enough MOAs, but even simple things like, do we have space? Do we have desks? You know, who's gonna take which rooms? This all takes time to plan it and think it through, and sometimes it takes finances too. And then throughout the first weeks, Jennifer needed quite a lot of support because she was very new. She was new to the country. She was new to Gabriola. She was new to the clinic. She was new to computer system, and she was new to our patients. And patients on Gabriola Island are older, and they're very complex often. So there's not many contraceptive calls. We usually have calls of somebody wondering if they can have a valve surgery with their renal failure, uncontrolled diabetes, and family drama, and that doesn't take 10 minutes to address. So it was a new environment for her, and that really took time, and she required support. And I think she tuned in really well. But I would say it took a few months before she was just smooth and happy and even killed with everything that was happening. And that was, I think, our last point. There is the contract, you know, involves a few things, and you know, Jennifer was happy for me to share with you the information. So Jennifer basically has about $150,000 in her contract. This is for 3 years. There is $75,000 overhead annually, and this is the money basically we used to pay for the new MOA. But then we were trying to figure out what's the fair share of her overhead, and part of the overhead that basically she's given, we decided to keep in a clinic as a payment for those 6 weeks of holidays. So this is how we sorted this problem out. But then again, that created a conflict, because if we didn't charge her the full overhead, anything we don't charge, it goes back to Jennifer. And obviously it's in our interest for Jennifer to earn as much money as she can. So again, it's left on physicians and a nurse practitioner to negotiate this and find a good solution to it. I think Jennifer has to work, she's working 4 days a week, and her contract is a standard contract for 1,680 hours a year, meaning that whenever she works, she needs to work 36 hours a week. She is an independent contractor, so that's another part for the nurse practitioner working in a rural community. It's not like a nurse practitioner working in a hospital or working basically in a city, where I understand they have benefits. Jennifer doesn't have any benefits from VHAR. You know, she's a little bit an outcast, as all privately independent contractor are. There is no sick leave, you know, there's no maternity leave. And I think this is a massive gap, and it's interesting that this is still legal in today's day and time, when basically independent contractors are outside of labor laws coverage. And that's another discussion for this PCN contraction. I don't think that should be right. I think this works against us all trying to provide services in rural places. And the way it's all structured, it's the ministry that gives the funds over to VHAR. VHAR does the admin part and administrative part, and basically just pays Jennifer, and that's how it all works. Yeah, and then what's happening right now, and what the contract also talks about, is that she's providing a full range of primary care services and also emergency services. We all have a day when each one of us is on call in our own clinic, meaning in the daytime we look anybody who's walking through the door or who's being brought by an ambulance. The panel sizes are important. So Jennifer contract is geared up to attach the unattached patients. So she is not there to look after our patients. She's there to pick up new patients from a community and provide care to them, people who don't have primary care providers anywhere. Her first year minimum is 400 patients that she's supposed to have. And within 3 years, she is supposed to build up a list of 800 patients. And we are not sure if this is realistic, because with the level of complexity we have on the island, I think 600 patients will be plenty of work, especially with her half-an-hour appointments. We just don't think physically she's able to provide care to more people. So we'll have to see. We know that nurse practitioners in in Nanaimo, none of them has 800 patients. Few of them have 600 patients, and population there is more biased. They have younger practices with kids and with young adults who don't require much help. But this will be part of renegotiations, I think. Once a contract comes to an end in 3 years, we'll be talking to VHA and probably Ministry of Health again, and we'll see. And yes, we did have to hire an MOA, so that again, it does raise up our cost again, just to be able to function, not even mentioning the holiday issue. And I think this is all we thought of really bringing into this meeting, and I would welcome any thoughts or questions.
There's a couple of questions in the chat as well. So the most recent question, well, it's sort of more of a comment about how, who said it? Monica said that she wasn't sure about different areas, but they were under the impression that any funds from the overhead that wasn't used went back to the Ministry of Health, whereas we were told directly any funds from the overhead portion that weren't used went directly to the NP herself. So that's an interesting difference.
That is a very interesting difference, because they directly told us that any unused overhead funds would go straight to Jennifer, which put pressure on us to try to, give as much of the overhead as we can. But again, we all new to this. Maybe nobody actually knew about this. Maybe they would in fact go to the ministry. So that's a fact worth checking.
Perhaps we won't check. It might disrupt your Apple Cart.
So that is a problem. And what I don't like about this is, we all need to trust each other and avoid conflicts whenever possible. But yet this problem is just dropped on the frontline workers. You guys sorted out this hardest part when it comes to actually division of money. It's not a pleasant thing to have. And we're all trying to be fair, but also it would be nice to avoid conflict.
Do we have any other questions? There's a comment from Greg that he said that they were understanding that the overhead portion is fixed, and it probably won't cover the overhead wherever he is. And so how would you manage that scenario is Greg's question, I think, to everyone.
Greg, I think you have a great question, and I don't know what's the answer to this, because you're absolutely right. I mean, it might be cheaper in our clinic to have an overhead for our nurse. Maybe the cost is less. But if you have to, let's say, hire a new building, then hire an MOA to be able to manage working with a nurse, the cost might be much higher than $75,000. And as far as I know, there's no additional funding. Karen.
I was just going to say, we have the one nurse practitioner, and since I'm in a group with 5 other physicians, and we're not great at record keeping and bookkeeping and really actually knowing what our costs are, I'll just put that out there. And with our very rudimentary calculations, we just are cost sharing associates, and we split up the costs depending on how much we work. And it was clear that the overhead the nurse practitioner came with did not cover what we pay, but we decided it was worth trying it out. Like it was a good experiment. We liked the nurse practitioner. We needed another provider, sort of similar story. And with just one nurse practitioner and 5 of us, it really isn't the end of the world. But now that we're looking to add 2 more, having 3 of 8 providers, then that becomes a significant proportion. And if we needed to do renovations to do that, I mean, there's some GPSC funding now, but there are a lot of considerations with that. And it isn't specific to the nurse practitioners. It would be any contracted sort of PCN resource. So it is a really interesting question in that, how do you measure that value to that person to your community? Not just financially. Absolutely, Karen. Absolutely. And, I salute you and all the other doctors trying to always make it work for their community. But, we all pay taxes, and we have the Ministry of Health, and they are mandated to provide services as services are needed to people who pay taxes. Why is it on people who actually provide services to use their own private money
to actually provide the services the community needs. So that's one part of this. Second part is our patients do not know, and they don't really care much, to be entirely honest, who is paying for what. They just want to have access. They want to have good access. They want to have timely access. And they are right. They are paying taxes. They should expect something back from it. So it's a fascinating ethical question. And I'm super happy. You know, I think most clinics, I like to think, would do something for their community, even so they take the financial hit. But you know, primary care together with pediatrics, mental health, we are the least paid groups in a medical healthcare system. And yet we are probably the only one volunteering additional money. I've never heard of gynecological office hiring a social worker to address the, you know, teen pregnancy problems. Maybe it's happening somewhere in urban places, but I've never heard of it.
Point, Maciej. Greg has David, sorry, has a question. Ultimately, what is the value proposition of having an NP in your office? So we talked a bit about the finances. Maybe he means beyond that.
What's the value? The value obviously is there is more services being provided to the community. Also, the fact that they have longer appointments and see less patients, that's also a great value. It's just a different way of working. She can really spend time talking to our patients to her patients but I feel people with complex and chronic conditions do get a little bit better care if there is more time allocated for them, because she can really get to know them. She can really get to know their personality, adjust the medical knowledge to their understanding. And I think overall, that's probably a better job than, you know, fee-for-service doctor trying to address everything in 10-minute windows and just rush through things. The other value is, you know, and I hope that for the future, if we make sure this model works and there is more attached patients, perhaps ministry will turn around saying, oh yeah, it's worth maybe, you know, allocating more funding to make sure this system would work and it's renewable. So that would be good. Greg, another great question. Are the complex patient channeled to the NP? This is what we thought when we were signing up for a process, meaning it would be great to have a nurse, because then we can group all those complex care patients, move them to her, but none of them can happen because this contract is for unattached patients. So she's a separate practitioner. We have to look after our patients. So our complex care patients receive care only from ourselves, but our nurse on this contract cannot look after our patients. She's completely excluded because it's a system designed to absorb the unattached patients. So it's a fair point. We were hopeful when we are talking about getting a nurse, and I agree that's a problem, because that's not how we saw it working, but that's what we were offered. And
one thing that you guys are working on right now is trying to equalize the panel. So even though the nurse is expected to be doing new admissions, you guys are working at trying to distribute your complex patients a little more evenly across the 5 panels.
Mm-hmm. And David may mention that often as practitioners struggle with looking after very complex patients just because they are trained differently and not to the same level as we are. That's so very true, David. At least a few times a week, I sit down with our nurse and talk about her patient because the complexity is just too high, and we cannot pick each other's ear all the time. But it's quite clear there is this border that nobody knows where it lies between competency, her feeling confident enough to take on another complex issue, and we have a lot of discussions about those very complex patients. So it is not like having another doctor in the office, that's for sure. You know, we in a sense we got 2 new doctors who are cruising along, and the amount of support they get is nil, because they've seen it all. They can do it all. They've been working for a long time. So it is a problem. It's not an equivalent workforce. You know, she sees less patients, and oftentimes we spend time talking about our complex or her complex patients. And Lawrence mentioned that you don't like the idea that the most complex patients are given to the nurse. You're absolutely right. It should be a support role, I think, for the nurse. So previously, when you were free to hire a nurse, we could hire a nurse using our own money and then ask her to do chronic disease management, meaning talk about lifestyle, talk about general improvements. But when it comes to actually managing somebody very, very complex heart failure, that should be doctor's realm. And I think it's this cooperation. this position, early draw from a primary care network, is not that. It's not a support position. I think the ministry is trying to get the nurses to be the primary care providers and see patients, but I also don't believe that a clinic consisting of 7 nurse practitioners could exist successfully. They would struggle to make decisions. They would refer, they would need to have more help and some basically specialist help from, primary care providers. And there will be way more referrals, I think, if we have only nurses working in one place, way more phone calls, and the work would be slow. It wouldn't be probably financially efficient, not to mention that the service wouldn't be as good. So I think the key is somewhere in between. There has to be a mixture of doctors and nurses. I think it's unrealistic to expect people who are not fully trained to provide primary care. And what I also hope for the future is that, although this contract was very stiff and inflexible, it's a beginning, and maybe there'll be new contracts as we all progress with PCN. Maybe we'll have more to say. Maybe we could all negotiate more with VIHA and the ministry. Maybe everyone will understand the value of this. And I really hope that as we all go forward, everyone will have this enthusiasm that we had when we were hiring the nurse, to then modify it and tailor what it actually means, what needs to happen. And also, it's so complex because every community is different, and what we need from our nurse ideally is not what people in Tofino would need from the nurse there, or people basically in a bigger center. So that is an interesting question. And yeah, I don't know if anyone has any other comments or thoughts.
It's Helen here. I'm just curious. So Karen and Monica, you have a NP, early draw NP in Whistler. And did I hear that there was one on Sunshine Coast? Are there any other early draw NPs?
So if you mean Powell River, the Sunshine Coast,
Powell River,
us.
sorry,
Yeah,
David.
that's us, yeah.
And in Dawson Creek, we also have one.
An early draw. And I'm just wondering what your experience was. Is it similar to what has been talked about?
Well, I think it comes, as far as Powell River, it comes down to personality. Like Karen, we get on well with our NP. However, she always arrives at the office after I do. She always leaves before I do. She takes way more holiday. I cover her patients when she's on holiday. She doesn't cover our patients when we're away. The patients love her because she spends way more time with the patients. Her competency level is not the same as doctors. As was said, it's difficult not to make it a personality thing because we actually get on well with our NP. But I asked the idea about the value proposition. If the value proposition is attaching patients, then I would rather have a family doctor because they see more patients, they're more competent. I don't quite understand why NPs are put in the position that they have to be at the moment, that they can't be, that for instance, you can't integrate an MP and co-bill, and so that you can, with a nurse in practice. And it does set up this tension, and I'm not quite sure what the solution is to that. And I'm also not convinced of the economics of NPs trying to work in family physicians' offices.
Karen, go ahead.
Yeah, I really, as usual, agree with everything that David has said, and that is our experience as well. Definitely comes down to relationships, and we have a good relationship, and she's a nice person. Patients love her. But as we're trying to add more, it's going to be really difficult to talk my partners into sort of subsidizing that overhead, because you can argue that there is a different value to the NP than just the financial, but it is hard to ignore that. We are looking at, to David's point, trying some trials of physician extenders and using our new HDC data to see if we can in some way measure which has the most sort of financial value, attachment value, to try to look at that. That's a hard thing. If anybody has any great ideas, I'd love to hear them. It's a hard thing to measure.
I think, David, your point is great. I think the value, financial and service value in adding a nurse practitioner is less than adding a doctor. I think the value in having a nurse is, if there's no doctors, at least we have a nurse. I think that was our position. Basically, we were desperate with Tracy because it looked like we're gonna be just left to look after 5,000 really old people, and we knew we will not cope well. So that was our primary motivation. But when we talk about health economics, it probably doesn't make sense. But there's not much choice out there at the moment. I think the primary care in rural places is underfunded gravely, and this sector, the primary care in general, was not really a priority for Ministry of Health, I think, for decades, and we're struggling. There's some catching up we have to do when it comes to finances, and also our role in organizing the services. I think those services would only work if people working in communities who understand their needs will have a role in and say in the service being created.
I think if I can add that, speaking to the physician shortage, if there aren't any, do we need to be doing more trials of physician extenders?
It's a good point, Karen, because what you guys are doing, you are sponsoring a new service by covering a nurse. So we are helping to resuscitate system that doesn't work well, and because out of good heart, people are trying to have services for their community, and they support service that's dysfunctional, that's making this work environment unhealthy for all of us. But that's just, I think, our nature. I think that's how people who work in rural primary care are designed, to help people to make sure everyone is looked after. And we are not helping by helping, I think, often. And if we would create a crisis, that would be a point at which we could look into modernizing. But crisis always means bad outcomes for our patients, and nobody wants that.
Angela, I'm just looking at Liz's comments. Liz lives in Galliano, and they have an MP there. Maybe Liz, you could speak to your comment. Are you okay?
Oh yeah. First of all, I have done locums at Galliano, and I'm not in the thick of it in quite the same. Well, that's where I live. I mean, it's not that I'm not involved, and I'm now on the Galliano Healthcare Society board as well as the Rural and Remote Division board. It's so interesting to hear what this is about. I mean, we're maybe included in the Salt Spring Island Primary Care Network planning. This is very early days, and it may or may not work because Galliano and Salt Spring can't work easily together, for example. However, I was just listening to all of the comments about NPs and their limitations, and thinking back to the NP that I was working with at Galliano, who was there for a couple of years, shortly after completing her training. And she may be an extraordinary person. She took a full load. I mean, and I don't even know what the rules were about attachments. She was filling a place that had been previously filled by another NP. And so I'm going to say that I just think that I'm hearing a lot about the structural constraints that are placed on these contracts that just sound very frustrating and ridiculous from what you're saying, and the issues related to funding, and then the mentoring required. And I think in small clinics, the other thing we'd say at Galliano is that there's no clinical director. People are working there. We've got a couple at the moment, hopefully to increase very shortly, 2 half-time physicians. One of them who's been there a long time, wonderfully competent, but she's not in a supervisory role. I mean, there are certain issues related to how this is all laid out that seem to, we need to kind of continue to work on. And so that's kind of where I was coming from, which was that that nurse practitioner happened to come to Galliano this weekend and become married here. And we went for dinner, and she talked about what a wonderful experience it is for her. Now she is in the urban setting, but there are 6 nurse practitioners at the 8th Primary Care Clinic in Victoria, no family physicians, providing a pretty comprehensive primary care. Just saying that there may be different models of care. And the other thing it seems is that this business about, my other observation is, from what I've heard, that you're talking about this business about taking care of unattached patients, and then it seems like that's almost comes out of a fee-for-service model somehow. Like you as the community physicians are going to take advantage of this person to offload some of your work. I mean, that, you wonder what the thinking is there. Whereas it's the clinic that needs to figure out how to attach as many as possible, and you work out the best way with the best model of care. So, I mean, I guess the fact that I'm running off at the mouth here just indicates just exactly how fruitful this discussion is for somebody who's not familiar with it. And I really appreciate everybody's contribution. Thank you.
I think when you spoke about sort of how well it worked with the 6 NPs, it reminded me of a clinic we worked, it was with the South Island, and it was integrating midwives and physicians in a maternity clinic. And we spent so many hours talking about the different models of care and then how they were going to work together. And it was so complex. It was really challenging. I don't think it ever happened. I think there was just so much variation in the model of compensation and how they see patients. And, there's a number of approaches discussed, but they could never get agreement on it. It was really tricky.
And, I've got a feeling we're finishing on a little bit darker note than I thought this discussion would finish, because yes, there are all those restrictions, but I cannot tell you how much I enjoy working with Jennifer Lewis and how important she became as a part of our team. And that's a value too, in many ways. I know financially it doesn't look that great, but there's different values, and she's a great person. So we got very lucky with her fitting into the team greatly, and it's a wonderful person to have around. It doesn't always happen like this, and I fully appreciate that. So, as you say, Helen, this is such a complex and I think unpredictable model. I don't think you can really predict it and see what the unforeseen consequences, what the blind spot in everybody's knowledge and understanding of those contracts and admin part and different roles and coverage and attachment is. It's almost like trying something to see if it will work, and without trying, you just cannot figure it out. It's too complex.
So it sounds like the conversation is, we're starting to wrap up here a little bit. I'm just checking in with Angela, who's facilitating the session, in terms of how much time we have left.
I think we have about 15 minutes left. So there are a few more comments, and if anyone else has any more questions, we do have more time. It's very challenging to do this chat box part on top of a facilitation. I think Don has his hand up.
Yeah, I'm trying to understand the potential role for the rural and remote doctors division in terms of participating in such discussions, because I do think it's a kind of a general discussion, because this is an opportunity in the province, and the experience that's been gathered so far, the pluses and challenges. So do you have any comments from your experience, Maciej, as to how the division might enter or participate?
Well, my initial thought, yes, Don, I do. I think it would be essential for division to represent us whenever a ministry is creating any new contracts for rural communities, being actually a nurse practitioner contract, and nurse practitioners are now part of rural and remote division as members. And and they are our members, and we should actually have a say in the way that those contracts are being created to ensure that they can be modified to any specific community. That would be my tip for all in remote division as our leader and as long-term strategic overseer. This, I think this is the role they could play. Because if we had freedom in job description, adjusting the nurse to the position, and if we had solid financial rules, it would be easier to decide if this is something our community will benefit from or not. I can see that Greg asked if there was an experience of hiring when there was more than one nurse practitioner was applying for a job. I don't know if anyone was in this position, because I truly believe that just creating a position will not, in the current conditions, there is no nurses out there. I think you need to really have a nurse first and then create all this position. And I'll be very curious to hear if anyone lives or works in a community when they had one posting and few nurses applying.
We actually had more than one nurse apply for our position on Gabriola.
Oh, that's right. We did. Tracy, do you remember the other nurse?
Yeah, so the other nurse practitioner that applied was a newer to practice nurse practitioner who didn't have any direct knowledge of our community. And so it was a different kind of scenario. So in that situation, I'm not sure, Greg, if you're thinking about like, how do you make a decision between people if we're not aware of scope or different things? And so in our case, there was just the two that applied, but there was one who we hired, Jennifer Lewis, who was clearly more of a fit for our community, but we did have more than one application.
Yeah, so with PCN work, my understanding is that human resources is channeled through the health authority. And if there is any sense of seniority here with nurse practitioners, I'm wondering, did the GPs have any say in who was going to come into their clinic, for example? Maybe seniority was not something they wanted there if different NPs seemed to be a better fit for their clinic. So I'm just wondering, how is this navigated in different PCNs?
Greg, this is a great question. I think we all don't like seniority because sometimes we have great candidates with less seniority who are superseded by somebody who did something completely different, but they have a bigger seniority. And I don't know how to answer your question. We were given the impression that when we create a job description, the candidate fitting the job description better will be the one selected, but I don't know if we were in a situation when there were two similar candidates, if seniority will pop in or not. I actually don't know.
We have a comment from Cheryl, and Monica's got her hand up. I think they might have something to add about this. Wait, go ahead, Monica.
Thank you. We have recently gone through a nurse practitioner recruit as part of a PCN early draw. The contracts have yet to be signed, so I won't go into huge details, but our understanding through that process, and we did have 2 applicants, was that this was not a health authority owned site that the nurse practitioner would be practicing in. They would be practicing in a private practice in partnership with other physicians. So in that situation, the seniority of the nurse practitioner applicants did not hold much weight during the interview process. Had it been a health authority owned and operated site, then yes, seniority would have come into play, but was only one of a number of factors. So unlike a regular unionized hire, it wasn't the defining factor, but it was heavily weighted. So really that clarity around whether this person is working in a health authority owned and operated site or a UPCC, for example, versus they are partnered in a private practice. There's your line in the sand to, I think, begin that discussion.
Thanks, Monica. That's really helpful. Cheryl, it looks like you have another experience as well. Do you mind telling us a little bit about that?
Sure. I just work as an engagement partner with Doctors of BC. This was the Shuswap region, also really small community, and it was also an early draw NP position, and identical to what Monica said. So the clinic is, it's not run by the health authority. It's in part with physicians and in part with like a local health society. So there were two applicants, two NP applicants, and it was identical to what Monica had said. It didn't go by seniority with the NPs. It was a combination of local health authority partner that interviewed, as well as the division ED and the physicians that were all part of that interview process. And so then they were able to determine the best fit NP rather than just strictly going by seniority.
Great, thank you. Does anyone else have any other questions? Don's got his hand up.
I just wanted to ask Cheryl, how's it working out in terms of the way that the load is shared? And is it the same that your nurse practitioner has to build up from patients who are not now covered, or how did that work?
Yeah, with the net new attachments, you mean? So the NP will have 3 years to build up their panel in rural area to 800. I want to say the first year is either, I think it's 200 or 300. I can't remember the number, but that they just need to commit to adding that number of patients the first year. Then the second year, they add a few more hundred, and then to the third year, then 800. But yes, it's considered net new patients, and they would do attachment codes to demonstrate that.
Okay, so we have about 10 minutes left. Does anyone have any more questions? This was quite the discussion we've had.
Yeah, just one more question. How fixed is that fixed 75,000 overhead that comes as part of the contract?
It's very fixed. So we were given the number. There was no discussion about it. We were told we don't have to kind of claim the whole 75,000, but it's a fixed number. So Greg, the negotiation about contract, I wouldn't call it negotiation. It was more like, this is the contract. You might like it or you might not like it.
Does anyone else have any other experiences with the overhead amount? Monica?
Just, I'm not certain how accurate this still is, so take it with a grain of salt, but originally the urban sites were offered 85K in overhead and the rural sites were offered 75. I think Galiano and some of the coastal communities it's not cheap real estate. There's a difference between finding clinic space, out in the middle of BC versus in Whistler or, on Pender Island. Perhaps as a group, that might be something that needs to be advocated for, as some equity to overhead costs based on, net square footage of real estate in that region, or something that is more accurate than just that rural urban divide. So yes, it's fixed at 75, and we pushed for a higher amount as a rural site. If we had been in downtown Vancouver, perhaps we could have gotten 85.
I think the unfortunate thing is that the overhead is paid to the NP, and then it's up to the physicians and the NPs to negotiate what percentage of overhead will the NP then donate to the clinic. And in the NP contract, it actually says that part of the overhead is to pay for continuing medical education for the NP. So therefore, you don't want to advocate for getting all of the overhead, but at the same time, in order to actually cover the costs of the NP, you need to get quite a lot of the overhead. It puts up a tension again between physicians and NPs, because you're trying to be the nice guy, but at the same time, you don't want to be paying to have an MP working in your office. And it would be much easier if the overhead went straight to the office and the NPs got a separate fund for their CME.
I think, David, you bang on. I think any inequality, whenever you work in an environment when you feel you're working more than people who get paid more, which makes no sense, leads to long-term conflicts and tension. Practically how it looks like, just a tip, we actually, the money for overhead, you know, the amount we decided to charge is actually going to the clinic automatically. So she doesn't have to, like, every month send money over to us. So it's a little bit more elegant than this, but the principle is the same. We had to decide that we're taking it away from her, and basically it lands with us, and it's not a good design.
I can speak to that experience because when we went through that, I'm Maciej's partner in his clinic on Gabriola, and sorry I joined late. But one of the things that we did is we felt that tension quite deeply around what was her money, what was the NP's money versus what was the clinic money. And so we just went through a really quite a good process of looking through the contract in detail, and then having our office manager go through our expenses in detail and really look at like staffing costs per hour, square foot rental costs, all of the different things that we pay for in overhead. And initially we weren't going to take the full $75,000 because we felt sort of deeply uncomfortable in that tension, as physicians do, around like, is this ours or is this hers, and are we being fair? But when we went through the funding practice model and actually looked at the cost, it was totally appropriate for us to take that amount, and it hasn't been a tension with her in any way. Have you, Maciej, had any tension around that overhead cost piece? But I would say that that's what would be worth doing in individual clinics, is really looking at what is your actual overhead cost and feeling confident to take the full amount that is appropriate, because that's the only way that we're ever going to be given the appropriate amounts, is if we take what is available.
So we talked about this twice, I think. I talked to Jennifer about this twice. She brought the subject, and I think the explanation, exactly what you mentioned, was really convincing, and I hope that she's at ease with this, but she did mention it to me twice. So again, having you know this conflict left with the practitioners is not a greatest solution. But I don't think it was a big deal.
Okay, well, this was a really good discussion. I pity the note taker, whoever that is. Greg, Greg has one last question. How do you fire an NP that's not working out?
Greg, that's a great question. Who's got the power to fire a nurse? I am not sure, and we read this contract so many times, and I don't know. Angela, do you know?
I think it's any party can terminate the contract, I believe. So Island Health could, the physicians could, or the NP could. That's my understanding. I didn't see anything, you know, specifically about, you know, the HR process. I didn't see anything like that in the contract, so I couldn't speak to that, but it did seem like any party can terminate the contract.
There's probably likely some conditions, and it probably isn't quite so straightforward. I think, Greg, is that perhaps what you're getting at? Who's on the hiring panel, and then who do you end up with, and what if it doesn't work out? There are definitely some potential risks.
Another good question: what happens to the patients if a nurse gets fired? Well, I wonder what happened then. I mean, again, everyone will look at us saying, "Oh, there's 800 patients who suddenly don't have a provider right now."
I guess that would probably be similar with any physician leaving a clinic. They're attached to the clinic, no matter who the provider is, I would think.
I just thought I'd jump in here quickly. There's a contract between the NP and the health authority to be an independent NP. There should be a separate agreement between the NP and the physician clinic to have a relationship for space. So when you say anyone can terminate the contract, it depends. The physicians can't say, health authority, cancel this contract, we're not happy. What the physicians have to do is make sure that their contract with the NP gives them an exit clause. And in answer to what probably happens with the patients, well, presuming the NP still has a relationship with the health authority, is still receiving funding, they can find another home and bring the patients with them. But that isn't necessarily the clinic's responsibility, although it would probably be wise to put that specifically in the contract that you have with your NP.
Those are excellent points. Thank you, Andrew. Okay, well, I imagine we could probably have this conversation for quite a bit longer, but I do think we're out of time now. So thank you all for joining us, and your next session starts at 2:45, I think.